My name is Terry Ketter. I'm professor of psychiatry and chief of the Bipolar Disorder Clinic at Stanford University, and want to talk a little bit about use of anticonvulsants in bipolar disorder. Probably one of the key things is that the anticonvulsants are highly variable in their beneficial and side effects, and only about 10% of the marketed anticonvulsants in the U.S. have indications for treatment of bipolar disorder, and maybe another 20% have some utility in comorbid conditions like substance use, migraine, anxiety, pain. So that leaves like 2/3 of them possibly without a use in bipolar. So you cannot assume that an anticonvulsant is useful in bipolar disorder. So the ones with indications are divalproex or valproate for acute mania, carbamazepine for acute mania, and lamotrigine for preventive treatment. And the sort of the son of carbamazepine, oxcarbazepine, has some data that is encouraging, but it's an underpowered study and it didn't separate from placebo, so we're not quite sure about that. So the two medicines that are approved for acute mania, they have side effects that are sort of somewhere between antidepressants and antipsychotics. So a little bit harder to take than antidepressants, but a little easier to take than antipsychotics. Lamotrigine, which is approved for preventing episodes, has tolerability that's by and large pretty similar to the antidepressants, so it's got pretty good somatic tolerability. The problem with lamotrigine is it doesn't seem to work in acute bipolar depression, and it's better at preventing depression than turning around an acute depression. The side effects of these medicines, lamotrigine, you can get a rare serious rash, 1 in 1,000, 1 in 3,000 people, but in general you have to treat like about 200 people to get one person to discontinue more than with placebo. So it's for the vast majority of patients, lamotrigine is very well tolerated. Carbamazepine and valproate have some tolerability challenges. They're not quite as challenging as antipsychotics with respect to, say, weight gain or sedation, and they don't cause akathisia or agitation, but carbamazepine has a boxed warning for serious rash, and there's even a genetic test for that of most use in Asian populations, and it also can cause some serious decreases in blood counts. Valproate has 3 box warnings. One of them is for liver toxicity, and another one is for birth defects, and it may actually be a little bit worse than some of the other ones with respect to birth defects, and another one for pancreatitis. That being said, probably the commonest disincentives to use these medicines are other things than the boxed warnings. So with carbamazepine, I would probably consider it to be the drug interactions. It decreases metabolism of multiple drugs, so you can't be really sure that these other medicines are at sufficient blood levels to do the job. And with valproate, some people get sedation, some get weight gain, some get tremor. It doesn't seem to have the metabolic challenges that the antipsychotics have, but it does have a weight gain issue. Carbamazepine, it's got a low propensity for weight gain. It's generally, most patients don't have problematic weight gain with carbamazepine. Okay, so if we look at the role of pharmacotherapy for bipolar, we have 19 approved treatments now, 19 indications, and 10 are for acute mania. There's only 2 for bipolar depression and 7 for preventive treatment. So the main unmet need is bipolar depression because we only have 2 indicated treatments. And not only are there too few treatments for bipolar depression, both of these treatments have a component that is a second-generation antipsychotic that has side effects. So for the olanzapine-fluoxetine combination, it's primarily weight gain that can lead to metabolic problems. and at least in the short term for quetiapine, it's sedation. And so we need to try to find something that's better tolerated, and if you have a tolerability first approach, you might think of using something different. And a lot of clinicians vote with their feet and try to use antidepressants, and in my view, they're well tolerated physically, so you hit that point that you want to hit, but they don't get the job done on mood. Okay, so they don't separate from placebo. Another one is this anticonvulsant lamotrigine that's good enough at delaying depression, but it falls just short of the mark at reversing an acute depression. And so its tolerability is just fine, but its effect size in treating the acute bipolar depression was just a hair less than was necessary, so it didn't get an indication. There are some new anticonvulsants on the horizon, and if you look at the time from getting an epilepsy indication to getting a mood disorder indication, this can be decades some of the time. And so how can we tell if these new anticonvulsants are going to be useful? Well, several of them have warnings for behavioral toxicity. And the most severe would be like a box warning for, homicidal ideation or something like that. And so if an anticonvulsant has that kind of warning, then it might not be a good idea for a mood disorder patient. And in fact, the 3 anticonvulsants that are FDA approved for treating mood disorders do not have any behavioral toxicity warnings. So that could be some kind of an early marker that you could use perhaps to pre-screen these. I would not be blasé about these behavioral warnings for the anticonvulsants.